which participate in uric acid elimination. 70% of uric acid is due to renal excretion, and only 30% of uric acid is due to gut elimination. Gout occurs when monosodium urate crystals under physiological conditions, when its concentration exceeds its solubility over 6.8 milligram per deciliter, or 420 micrograms per liter. So when this level is going up, this physiologic condition, the concentration exceeds the solubility of uric acid, and then it transforms into crystals. Only 1 in 30 patients with hyperuricemia develop gout. Only 1 in 30 patients. So 29 patients out of these 30 have hyperuricemia, but they don't develop gout. Why? I don't know. There is a complicated mechanism, many mechanisms, not one. And this is why many patients live with this metabolic disturbance, hyperuricemia, but they don't develop gout. 90% of hyperuricemia is caused by underexcretion. So the biggest part of hyperuricemia is underexcreted, and the kidney is the main organ which accounts for the accumulation in uric acid in the blood. Most patients with recurrent gout attacks will require medication to lower the serum uric acid. So when you have patient with high level of uric acid in the serum, you have to lower it in order to eliminate this main reason for gouty crisis. The upper limit of the solubility of urate in the serum is 6.8 milligrams per deciliter. Urate crystallizes as a monosodium salt in oversaturated joint tissues. Joint tissues, when there is a uric acid oversaturated, they transform into crystals, and these crystals cause the inflammation, which is termed as a gout crisis. At decreased temperature of periphery, for example, feet, solubility is even less. So when the patient goes out in winter, for example, or there is a decreased temperature of periphery, feet, hands, and so on, this solubility of uric acid is less. So this is a condition for getting gouty crisis. Which are the risk factors for gouty attacks? The first one is high purine diet: red meat, fatty poultry, high fatty dairy, seafood, and so on. Alcohol consumption, trauma, osteoarthritis, surgery, starvation, dehydration, obesity, many drugs, allopurinol, uricosuric agents, thiazides, loop diuretics, low dose aspirin, all of them are risk factors for gouty, for elevating uric acid in the serum and gouty crisis. Renal impairment also, and genetic mutations. You see here there are 3 types of genetic mutations. These are genes in the tubules in the kidneys, which can cause, these genetic mutations can cause the hyper reabsorption of uric acid in the tubules and accumulating in the blood. It is well known that gout has 4 stages. The first one is asymptomatic tissue deposition. The second one is acute gouty arthritis. The third one is intercritical gout. This is the period between the crises. And the fourth, the more severe, is chronic articular and Toffa-Zell's gout. Which are the clinical, the main clinical symptoms and syndromes? The first one is acute gouty arthritis, the crisis. The first episode that is usually preceded by hyperuricemia for many years. The most often affected joint is MTP joint. This is why it is called podagra. It accounts for 50% of the patients. Other foot joints, for example, ankle, knee, accounts for 30% for the first time cases. Usually monoarticular, the Gouty crisis is monoarticular in 80% of patients with the first case, but it can be polyarticular in recurrent cases. The crisis is characterized by pain, very severe pain, erythema, swelling, and warmth, the typical changes for inflammation. There is sometimes there could be desquamation of the skin. There can be fever or leukocytosis, and maximal severity is reached with first 12 to 24 hours from the beginning of the crisis. Even without treatment, attacks subside with days to several weeks. But most often, your patients will need to be prescribed medication in order to shorten this period of crisis. Now you look here on the picture. This is the first MTP, big 2, where you have redness, swelling, pain. It's a typical Gouty crisis, and you cannot make mistake with. You have to differentiate only with bacterial arthritis. But when the patient has bacterial arthritis, she or he more often must have the reason for that. These are schematically presented the places and zone joint places where Gouty crisis can happen. You see here the toe, the ankle, tarsal region of the foot, knee, elbow, and less often here the small fingers, joint of the small fingers of the hands, the wrists, and so on. Here I show you again pictures with typical crisis. Here also this left foot is affected. You see here the acute gout of the small finger joints of the hands. You see here the Gouty crisis of the ankle. You see the acute Gouty crisis of the dorsum of the feet. This is the joint knee with the fusion, big effusion caused by Gouty crisis here and here and here. Always, if you have such types of effusions, especially in the knee, you have to make a punction, diagnostic punction, and to investigate the synovial fluid for crystals and leukocytes, of course. Chronic gout is characterized by chronic arthritis, which lasts more than 3 months, and it comprises tophi. You see here, these two lesions are tophi, resulting in chronic inflammatory and destructive changes. Here you see destructive changes here and here and here of the joints. Very often you'll face renal complications, especially nephrolithiasis and chronic urate nephropathy. Both of them are very important for renal complications for gout. The classical risk factor for gout are obese, hypertensive men, aged between 30 and 50, and frequent imbiber of alcohol, especially beer, and red wines. In women which are over 65 of age, the prevalence between men and women is equal. You see, when women are in menopause, over 60 or 65, this prevalence of Gouty crisis and gout equals to men prevalence. Trauma of the joint is also a risk factor. Hospitalization for anything, comprises 20% of Gouty sufferers who will have an attack in hospital, even though patients who are admitted to the hospital for surgical procedures. Diet high in meat and fish, chronic renal insufficiency, all these risk factors are very important to cause Gouty crisis. Also, you have to have in mind medications, especially diuretics, all diuretics, thiazides and furosemide, nicotinic acid, niacin, aspirin in low dose aspirin. For example, 100 milligram aspirin protect, or all types of aspirin which are intended for antithrombotic medication. Cyclosporin, ethambutol, pyrazinamide, levodopa, and many others. The diagnosis is based on the patient complaints. He can be febrile, white blood cells may be elevated, SED rate is between 50 and 80, CRP is also elevated, uric acid in 1/3 of the patients, between 20 and 40% of the patients, uric acid during the crisis may be normal at the time of attack. And when attack subsides and when it goes away, the uric acid can raise up to high levels, which shows that these patients have gout. Definitive diagnosis is made when you see intracellular monosodium urate crystals in synovial fluid, especially in leukocytes. Here, down right of you, you see these crystals. They're needle-shaped, here also. And arthrocentesis is very important procedure and should be done in patients in whom the diagnosis has not been previously established. Labs investigation show cell count with differential. You have to make a cell count with differential measurement and count. Gram stain, culture examination for crystals under polarized light microscope. You see negatively birefringent. They're all monosodium urate crystals are negatively birefringent, and here on the picture they're shown in blue, in yellow, sorry. Shaped crystals, needle-shaped crystals, they're yellow when the crystals are parallel to poralize, and blue here on the right when they're perpendicular on the light of the polarized microscope. This is the opposite, vice versa, for calcium pyrophosphate dihydride crystals in Pseudo Gout. You see here many crystals of monosodium urates. This is, I said to you that they're negatively birefringent. And you see here the yellow picture when the polarized is parallel, and blue color of the crystal when it's perpendicular to the light. Here magnified and bigger magnifying. You see needle shaped, many crystals. This is from the synovial fluid. When you see this on microscope, it is 100% diagnosed. 100%. It is worthless to make another investigations if you found this picture on microscope. And this is why the microscopy is very important method of proving the diagnosis. A classic, how can you presumptive diagnose gout without arthrocentesis? Because some of you who are not rheumatologists and who will not become rheumatologists, they have to doubt for this diagnosis when you cannot make arthrocentesis. What these presumptive clinical signs can lead you to think about the disease. It's a classical history of one or more episodes of monoarticular arthritis followed by periods completely free of symptoms. You must remember that gout is the course of the gout is not like the course in rheumatoid arthritis, because rheumatoid arthritis is progressive chronic disease, and joint symptoms last for 3, 4, or 6 months and even more, with no periods of free of symptoms like in gout. Maximal inflammation becomes within 24 hours, and there is a rapid resolution with colchicine therapy. The colchicine therapy is a test for Gouty diagnosis. Hyperuricemia is also a sign, and subcortical bone cysts which are apparent on the X-ray. You have to make the differential diagnosis with septic arthritis, pseudo gout. This is caused by calcium crystals, calcium pyrophosphate crystals, and usually this pseudo gout affects knee or wrist. You have to make a diagnosis with reactive arthritis. You have to make a diagnosis with rheumatoid polyarticular arthritis, systemic lupus, psoriatic arthritis, etc. This diagnosis in differential plan, you have to think about them when the gouty course is polyarticular, because usually it is monoarticular, and if we have a polyarticular affecting of the joints, then you have to think about rheumatoid arthritis, psoriatic arthritis, or some other type of arthritis. Always consider the background information from the patient. This is the X-ray. I shall magnify to see better. You see here the toffee here, and you see here that this is a bone toffee, and this is a soft tissue tophus, and you see here also. And you see here the destructive changes of the first big two joint, the first MTP, which is very, very important here. Also, this is typical for gout. Typical. What is the treatment of acute episode? The acute episode, acute gout. The first drug and the mainstay of the therapy is colchicine. It must be, remember, the medicine must be started early, in the first 24 hours at the latest, in the first 24 hours of the beginning of the crisis. And the first day, the patient takes 3 tablets, 1.5 milligrams. So 1 tablet every 8 hours, and then 2 tablets daily every 12 hours. So the first day, the patient takes 3 tablets, 1 tablet every 8 hours for the first 24 hours, and then 2 tablets every 12 hours. The problem is virtually everyone gets diarrhea after the first 3 doses. The diarrhea is the most common side effect of colchicine. If colchicine works well, it is suggestive but not diagnostic of gout, not always in 100% diagnostic. Other serious problems which diminish the colchicine usage in gouty crisis are renal and hepatic injury, CNS dysfunction, neuromyopathy, especially in elderly patients or those with decreased renal or liver function. It's very important when you prescribe this dose of colchicine to have in mind that renal and liver function in those patients must be normal. Another type of medicines of drugs are non-steroidal anti-inflammatory drugs, especially indomethacin, which is given 50 milligrams every 2 hours for 24 to 48 hours, and then decrease to 25 milligrams 3 times a day, 3 to 5 days. It works very well, but there is a high risk of GI bleeding of this non-steroidal drug. Diclofenac is also very good in a daily dosage 150 milligrams or 75 every 12 hours or 50 milligrams every 8 hours. Almost any other non-steroidal will work if is given in high enough dose. But you have to remember that colchicine as well as non-steroidal drugs must be started early in the crisis when you see and diagnose the crisis. The main reason for not to use non-steroidal or to give them in a lower dose, half lower dose, it is renal insufficiency, hypertension, heart failure, and ulcers or bleeding that keeps one from utilizing these drugs. Corticosteroids are the another type of drug which can be given in serious and severe gouty crisis. We usually use prednisolone 40 to 60 milligram per day for 3 to 4 days, and then taper the dosage over 3 to 7 days. Triamcinolone 40 to 60 milligrams intramuscularly once injected, and intraarticular injection. The dose is dependent on the joint. If you have the big joint like a knee, then you have to inject the maximal dose, 80 milligrams of the pomodrol or intraarticular corticosteroid injection. You have to make sure yourself that you have the diagnosis absolutely sure before injecting the joint, because if the patient have bacterial arthritis and you inject corticosteroid, this will aggravate the clinical picture, and you have to change your therapy for the bacterial arthritis. When you initiate urate lowering therapy, it must be started out when the patient is out of crisis. So the patient must be free of crisis to start urate lowering therapy, because this therapy can precipitate acute gouty arthritis. Therefore, it is necessary to make a prophylaxis with colchicine or non-steroidal anti-inflammatory drug, often given together with urate lowering therapy. This is a scheme. You will see it, but it is very, very difficult to read because the letters are small. This is a scheme for the tactic and therapy management of the therapy of the gouty patients. Hyperuricemia, you must treat the hyperuricemia when gouty crises are 2 to 3 per year. So especially when they are more than 3 per year, you have to treat hyperuricemia. Asymptomatic uric acid, when it is more than 12, also you have to treat. When you have Toffa-Cell's gout, you have to treat hyperuricemia. When you have gout and any history of kidney stones is also the condition for treating hyperuricemia. The gout with renal insufficiency and acute uric acid nephropathy. When treated hyperuricemia, therapy is divided in different two main types of drugs. Most patients are under excretors, 85 to 90%. Those patients could be treated with uricosuric drugs. These drugs eliminate the uric acid from the kidney, like benzbromaron, probenecid, or sulfimpirazone. The most used medication is benzbromaron or Desuric, trade name. But these medications can cause kidney stones, renal insufficiency, and chronic Toffa-Cell's gout. So they are forbidden and not allowed in chronic Toffa-Cell's gout. There are some drug interactions and need to produce at least 1,500 milliliters urine per day. So the patients must take much quantity of water. The therapy started at 250 milligrams two times a day, increasing to 1,000 milligrams 2 or 3 times daily over several weeks. The target is to achieve uric acid level below 6 milligram per deciliter. You have to make a lab investigation of 24-hour urine for uric acid excretion to demonstrate that the patient is not an overproducer. So the patients can be divided in under excretors and overproducer. When you have overproducer patient, you have to treat it with urico inhibitors. When you have patient under excretors, you have to treat as an under excretors with this medication. The first xanthine oxidase inhibitor is allopurinol. The dosage is 100. You start at 100 milligrams daily for 2 weeks, and then increase, if there is no effect, increase by 100 milligrams 2 times a day until you reach 300 milligrams daily. Increase dose thereafter to achieve uric acid. The target is below 6 milligrams per deciliter. Adjust the dose. You must adjust the dose for creatinine clearance less than 80 milliliter per minute. Drug interactions are many with cyclophosphamide, azathioprine, mercaptopurine. This increase the incidence of rash with ampicillin, especially, and problems. They arise from 3 to 5%, which develop rash and leukopenia, thrombocytopenia, diarrhea, and drug fever. One patient in 1,000, so it is 1 per mile, will develop allopurinol hypersensitivity syndrome, which concludes rash, comprises rash, fever, hepatitis, eosinophilia, acute renal failure, with up to 25% mortality. You see how high is the mortality in these patients who develop allopurinol hypersensitivity syndrome. Another modern drug is Pheboxostab. It's also xanthine oxidase inhibitor. It is adenuric in our market, Bulgarian market, pharmacy market here. This is a new drug. There are some drug interaction, expensive when compared to allopurinol. You have to start at 40 milligrams minimal daily dose and increase to 80 milligrams if not at goal in 2 to 4 weeks. So if you didn't achieve the uric acid level to normal 360 or 380 microliters per liter, then you have to increase the dose up to 80 milligrams. Monitor liver function tests periodically, hepatic intoxication, and this drug increased the incidence of cardiovascular events compared to allopurinol. So when you have patients with cardiovascular diseases, comorbidity with heart failure or hypertension, you have to pay attention for these complications when you use this drug. When should we use colchicine as a prophylaxis? When the crises are more than 3-4 years. And the dosage of colchicine for prophylaxis depends on the creatinine clearance. Don't use if less than 10 milliliter per minute of creatinine clearance, and take 2-3 days if it is 10 to 20 milliliters per. So you have to have in mind the creatinine clearance for the dosage of colchicine prophylaxis. Use the first 3 to 6 months when instituting uric acid lowering therapy. There is another drug which is called Transboricase. It is intravenous medication to be used to prevent tumor lysis syndrome, but this drug is very expensive and there are many allergic and side reactions when we use it. Yeah. This is a recommendations of practice. This is like a guideline how to treat in practice Gouty crisis and Gouty hyperuricemia. This is the diet, general health diet and lifestyle measures for Gouty patients. Now some words to tell you about Pseudo Gout. This is another type of crystal arthropathy, which is caused by calcium crystals, especially calcium pyrophosphate crystal deposition, and it is called Cppd. This is a syndrome secondary to calcium pyrophosphate in articular tissues. This Cppd includes chondrocalcinosis, chronic Cppd, and Pseudo Gout. So 3 types of diseases can be included of this calcium pyrophosphate crystal deposition. The etiology is unknown, but can be secondary to changes in the cartilage matrix or secondary to elevated levels of calcium or inorganic pyrophosphate. The pathology of Cppd crystals, the Cppd disease, these crystals, Cppd crystals, are found in the joint capsule or fibrocartilaginous structures and there is neutrophil infiltration and erosions. Almost the same in the gout, but the crystals are quite different. You see here they are small. These are the leukocytes, and inside the leukocyte there is a small rhomboid-shaped crystal. It's very small, much smaller than Gouty, than the monosodium urate crystals. About demographics, it is predominantly disease of the elderly patients. The peak age is between 65 and 75 years old, and there is a female predominance, female to male, about from 2 to 7 by 1. So the females are much more affected than men. The prevalence of chondrocalcinosis is 5 to 8% in general population without symptoms. You can find it very very rare when you take picture of the knee, for example, or on the occasion, for example, of trauma or some other complaint in the knee joints of the patients. What are the disease associations of this crystal arthropathy? You have to always to have in mind all these diseases, and this is called disease associations: hyperthyroidism, hypocalciuria, hypercalcemia, hemochromatosis, hemosiderosis, hypophosphatasia, and so on. You see here hypothyroidism, neuropathic joints, amyloidosis, trauma, and so on. What are the clinical manifestations? The first picture is pseudo gout. It resembles the urate gout. Usually presents with acute self-limited attacks resembling acute gout. The knee is involved. The main joint, which is involved, the knee, in 50% of the cases, followed by the wrist, shoulder, ankle, and elbow. You see here that the most often involved joints are middle or big joints: shoulder, ankle, elbow. In 5% of patients, gout can coexist with pseudo gout. So both types of gout can be met together. The diagnosis is confirmed with the synovial fluid analysis and/or the presence of chondrocalcinosis and radiographs. Acute pseudo gout primarily affects men. The chronic Cppd is another type of pseudo gout. This predominantly affects women. It is a progressive, often symmetric polyarthritis. Usually affects knees, wrists, second and third MCPs. It resembles rheumatoid arthritis, hips, spine, shoulders, elbows, and ankles. Chronic Cppd differs from pseudo gout in its chronicity, involvement of the spine, and MCPs. And chondrocalcinosis, another type of pseudo gout, is of Cppd, is generally incidental finding in X-rays. Diagnostic test, inflammatory cell count, which are diagnostic tests for this type of crystal arthropathy. Inflammatory cell count in the synovial fluid, rhomboidal in comparison to needle-shaped crystals of urate gout, or rod-like intracellular crystals. Imaging studies reveal chondrocalcinosis usually in the knee, but it can be seen in radial joints, symphysis pubis, and intervertebral vertebral discs. Differential diagnosis could be made, and it includes septic arthritis, urate gout, inflammatory osteoarthritis, rheumatoid arthritis, neuropathic arthritis, and hypertrophic osteoarthropathy. You can see here, I don't see that it is seen very well, but you can see it here. This here is calcium deposition in the wrist of the patient. The therapy includes, it is similar to classic gout, and it includes intraarticular corticosteroids. Colchicine can be used in acute attacks and also on prophylaxis. There is no specific treatment for this chronic Cppd. It's important to treat secondary cause, and colchicine could be helpful. This is shown here, the schematic structure of the knee, and where you have to make the punction with the needle intraarticularly. This is a schematic presentation of shoulder, and also this is the bursa subacromialis, and here are the needles where we have to make the punctions in different conditions, pathological conditions. Here is the schematic presentation of the wrist and the hand and the foot, of course. And this is in the United States, I think, when we receiving the milk from the cows directly to the mouth of cats. So, dear colleagues, this was all for today and for the semester. So if you have any questions, please tell them and you can share your opinion about rheumatology. In your practice, nevertheless you become a rheumatologist or internist or surgeons or whatever specialty you have, you must have in mind that rheumatic diseases are very, very important. They can affect young age, and they can be disabling, and they can resemble many other types of disease, and you have to have much knowledge about these diseases in order to refer all patients to rheumatologists. If you have some questions and if you want to tell me anything of your opinion, you can do that now.
It was very useful, all you teach us. Thank you for your time and for your teaching.
So you're welcome all the time when you need. When you need help, when you need advice, when you need to know some more, you have to join me and to come to discuss or to talk about that. And I wish a good session, a successful session, the most important, and to reach the final stage of your graduating to become a doctor.
Thank you very much, Professor.
Okay.
All the
Till
best.
next time.
Bye-bye.
Thank
See you.
you. Bye bye.